Good morning, respected teachers, seniors. Today we are here to discuss a case. I am Vivek Kumar Das from CMCTL, second year resident. I will be presenting a case of a 25-year-old female from Bhavani Rural Municipality, Varsa. She is a student, unmarried, presenting complaint of painless breast lump in left upper quadrant for 5 months. Complaint was painless lump in the left upper outer quadrant of the breast since 9 months. Noticed during self-examination with no nipple discharge or skin changes, no history of trauma, no systemic symptoms like fever, weight loss, bone pain, fractures, jaundice, seizure, or loss of consciousness. Our past history, along with the course of disease, is given here. There is history of proteinuria for which she was evaluated and diagnosed as biopsy proven minimal change disease with proteinuria since 2 years. She is under immunotherapy of tacrolimus, mycophenolate mofetil, and cortisone. This is the report of the electron biopsy report. And she was evaluated for breast lump at Clear Hospital initially, and USG was done, which shows there is an ill-defined hypoechoic lesion noted in the left breast, 34 into 33 mm, at 2 o'clock position. Dilated duct in left breast, measuring 3.6, probably duct atresia. Few enlarged lymph node in left axilla, maintaining fatty hilum, and largest measuring 10 into 9.9 mm. This is the report. Two-cut biopsy was performed in TUTL. Which showed immunohistochemistry of ER-PR negative or two strongly competent membranes staining 70% of the tumor cell, KI 67-30%, and took it with invasive breast CA NST, Nottingham modification of Bloom-Richardson score 6 out of 9. Grade 2 modulatorily differentiated lymphovascular and peritoneal invasion was not identified. So the report. Following which she came to BPKMCH and was evaluated for breast CA. Our examination finding initially done was in the breast department, which showed bilateral breast symmetrical, no visible discoloration, swelling, discharge, deformity, no nipple discharge. On palpation, there was 4 by 4 cm marks in left upper outer quadrant of the breast, non-tender, hard in consistency, irregular shape, mobile, and in left axilla, single hard mobile lymph node was palpable, approximately 1 cm. She underwent NC CT chest, abdomen and pelvis, MRI breast, FNAC of left axillary lymph node, and CA 125. The report of the NCT chest in the beginning, when she came 5 months back, showed a heterogeneous mass of 45 into 38 mm into 37 mm in the lower quadrant of left breast, invading adjacent glandular and subcutaneous tissue. Skin thickening with enhancement noted in the left periareolar region and lower quadrant, along with skin changes with mild retraction of nipple, enhancing necrotic lymph node seen in the left axillary region, measuring about 23 into 24 mm. With other finding was benign cyst in bilateral adnenaxillary region on the left. So this scan. These are the first CT scan showing the left breast mass. MRI breast was done, which showed an irregular mass in the upper outer quadrant of the breast with metastatic left axillary lymph node, approximately 9.5 centimeter from the nipple, maintaining fat film with underlying pectoralis major muscle, no skin thickening or interaction noted. Edematous changes seen in fibroglandular tissue of the left breast. Few enlarged left axillary lymph nodes in one measuring 30 into 26 mm, showing restriction of diffusion. These were the MRI. FNAC of the left axillary lymph node was positive for malignancy, suggesting for metastatic deposit infiltrating breast carcinoma. And CA 125 also was performed, which showed increased from the baseline, 24.48. She was diagnosed as T2M plus M0 with ER-PR negative, HER2 positive breast CA, and advised for NSCT and chemotherapy started with trastuzumab, paclitaxel, and cyclophosphamide. After 3 cycles of chemotherapy, In J, we performed NCCT chest, abdomen pelvis, USG guided breast mass clipping with gold, BRCA1 and BRCA2 test, and technetium 99 MDT bone scan. The second CT scan showed irregular outline heterogeneous enhancing residual mass measuring 16 into 15 into 13 mm in lower outer quadrant of the left breast, invading adjacent subcutaneous and fibrocartilage tissue. Few left axillary lymphadenopathies are noted in the level. One measuring 135 into 13.5 into 10 mm, where the rest of the findings were not. This is the size of the second CT scan. BRCA and BRCA2 tests were negative, and technetium 99 bone scan also showed no integration. Currently, she has completed 6 cycles of chemotherapy, and on examination, the bilateral breast was symmetrical, no visible discoloration, no swelling, no discharge, no deformity. On palpation, the mass was of the similar size, 4 into 4 centimeter mass in left upper outer quadrant, which was non-tender, hard in consistency, irregular shape. Left anterior axilla palpable single hard lymph node, approximately 10 mm, was still present. Current CT scan. Summary. A 25-year-old unmarried female presented with approx 4 into 4 centimeter palpable, painless upper outer quadrant hard mass of left breast since 9 months with single mobile hard anterior axillary lymph node, approximately 1 centimeter size. She was diagnosed as T2N plus M0 HER2 negative, ER, BRCA negative, invasive breast carcinoma. Currently completed 6 cycles of NSCT with trastuzumab, paclitaxel, and cyclophosphamide with no regression in mass and node size. Minimal regression. I would like to join for the
Dr. Mahesh will just briefly summarize the things and what the literature says. Just for a few minutes, then we shall discuss about that.
Good morning, everyone. As we have heard about the case, Now I will briefly talk about breast cancer and its what the guidelines say and what we can expect from our team to decide on the further treatment of the patient. Starting with global impact, we know that breast cancer occurs as the second most common uh, cancer in worldwide, and with increased incidence in the Western while increased mortality in the Eastern and low-income country. There has been change in the trend of the incidence and as well as mortality of the breast cancer. Where we come is we among the 22,000 cases in 2022, there were 2,255 cases of breast cancer in female. And as we all know, we start with the investigation as a triple assessment with clinical imaging and pathology to diagnosis. When there is doubt, we go for nil biopsy or even open biopsy. As we know, there are three main categories of molecular subtypes of breast cancer, in which luminal A and luminal B come under luminal, then HER2 enriched and triple negative. So our patient comes as HER2 enriched breast cancer. So there are different pathophysiological differences in the different types of breast cancer, and there are cases in which there might be familial breast carcinoma as well. So sometimes TP53 mutation can be seen in patients with ER and HER2 positive cases, so on. So now coming to HER2 positive carcinoma, they usually are arising from the gene amplification of the HER2, which is chromosome 17q. It's seen in more than 95% of the HER2 carcinoma. So here we can see the FISH image of the slide. There is amplification of the HER2 genome in the chromosome 17. And nearly 20% of all breast carcinoma are positive, and sometimes we might get ER positive or sometimes negative. And most common subtype seen in this patient with germinal mutation is the TP53 mutation. So now coming to treatment as a whole, the treatment for breast carcinoma is multimodal, typically involving surgery, radiation therapy, and systemic treatments, which are tailored to individual patients and tumor characteristics. As we most commonly use the NCCN guideline, I'll be talking briefly about what guidelines say, and then we'll have the meeting directed toward the guiding the further treatment of the patient. So with the clinical workup, our patient came under the category of more than or equal to T2 with the clinically more positive patient. We just evaluate the patient as any other patient, and these patients have an option of surgery or to go for initial neoadjuvant chemotherapy, and for surgery we can go for BCS or mastectomy depending on the patient's choice and characteristics of the patient. So after surgery, we can go for advanced systemic therapy, and depending on the nodal status, we can go for radiotherapy as well, and also the margin status. So if BCS is a contraindication or is not appreciated by the patient, we can go for mastectomy as well. So while considering adjuvant systemic therapy, it can be based on histology and receptor status after the upfront surgery, whether the patient has ER positive or negative status and HER2 positive or negative status. So in patient with like our patient with the negative hormone receptor status and positive HER2 disease, with clinically node positive, and as this patient, if had undergone surgery, might have got a positive pathological node as well. So in this patient, we can go for adjuvant chemotherapy with trastuzumab, which is directed for the HER2 disease, and there are different dosing regimens advised in the NCCN guideline, and our patient underwent paclitaxel with cyclophosphamide, even though his docetaxel is given with trastuzumab, as the cycle has been is cycled. Every cycle is given every 21 days for 4 cycles of the chemotherapy, and which is also with trastuzumab. which is followed for about 1 year. But our patient received 6 cycles, and also there is a very marginal regression of the disease. So now to go for whether to go for surgery or not, or to go for more cycles of chemotherapy, this meeting will be directing our treatment. So if we are planning for surgery, we can either go for breast conserving surgery or mastectomy. But there are few contraindications to go for breast conserving surgery, like there is inflammatory breast cancer or invasive breast cancer, diffuse suspicious malignancy, inability to clear multiple positive pathologic margins, or other multisystem diseases. And sometimes there are related contraindications, like a patient with known genetic predisposition to breast cancer or pathologic TP53 mutation, or sometimes if the patient has active connective tissue disorder, which might preclude radiation treatment. And sometimes history of prior radiation therapy to the affected area with the knowledge of doses and volume fat input. So now what comes in our meeting is how to move the treatment for this patient. So now I would like to direct our meeting toward our respective faculty for provide them valuable information and the expert opinion regarding treatment of the patients. Thank you.
Thank you, Dr. Mahesh. So first, let's start with the patient. It's very interesting patient today. We should, besides the diagnosis and the staging, we must remember that she has got a many disease of the sort of the autoimmune pathology. So we should always keep in mind, because he has mentioned one of the factors that for the relative contraindication for radiation therapy is the connective tissue. It's also one of the forms, so we should always keep in mind regarding that. So within point, so let's start with the pre-operative workup, whether this patient was worked out properly or not. So I think the patient is young, so that's why the MRI was suggested. I think this is the good that we suggested for the MRI, because we never know exactly whether the contralateral breast involved or not, whether there's lymph nodes or not. So besides the ultrasound, which was done outside in the hospital, which we considered for the MRI and the CT scan for the proper staging, I think the staging was done pretty well in this particular patient, along with the biopsy of the breast region and FNA of the axilla, so it was proven well. So my first question would be the expert panel. Besides that, do we need to consider for PET scan this particular patient before starting the treatment or not? What's your opinion? Because we have not done PET scan in this patient. Now I will tell the details later on, but in the beginning, was it advisable or not? Do we need to advise the patient, of course, for that, wishes for that? Will it be recommended or not? Any
Question is no. One, RT is positive and ERP is negative. It means it is very high risk. So if available, we can do this.
That's good. So PET scan would have been recommended. So I talked later with the patient after completion of the 5 cycles of chemotherapy. I said you should go before any kind of, continuing the treatment, let's go for the PET scan. Or if you don't have the money, you'll go at least for the bone scan. So the patient part is said that for the financial constraints, they will go for the bone scan. So bone scanning was done after 5 cycles of chemotherapy. So anyway, whatever in our logistic scenario, with the financial constraints of the patient, whatever was done was great. So critical. So in the diagnostic workup, I think we don't need to add anything. Do you have anything to add on the diagnostic parameters for this particular patient? Everything was done well. The staging was just properly. The second thing, anything regarding the diet? Nothing. So the second thing I would say is the T2N1M0G2. The second, this was the moderately differentiated carcinoma, and HER positive ER negative. So I guess that this will come according to the prognostic category, third A stage clinical. Third A stage according to the prognostic criteria. So this is not very early. This is just be considered local stage. So now the next question comes: the patient. Do you need to consider the patient for upfront surgery or to go for the pre-operative treatment? The patient received the pre-operative treatment. Now we cannot go back, but just for discussion, was the upfront surgery possible, recommended in this patient or not? Clinically, T2N1 disease, perhaps single lymph node in the MRI, in the CT scan. Rest of the things were negative. So, what's your opinion?
The use of neoadjuvant chemotherapy in this setting justifies the events. So the patient is treated with node positive disease as well as RD. So the neoadjuvant chemotherapy in this case is justified.
So, you are in favor of the neoadjuvant. Any evidence for that? Would you suggest the evidence that in a resectable disease, this is N1 disease, in a resectable disease, there is definitive evidence that preoperative chemo scores over the adjuvant chemo?
Survival benefits in case of RD, people survival benefits in case of, like in that case of triple negative. But even in opposite cases, for example, if we have both where close, so that's why we actually there followed by surgery. As we mentioned from the exercise.
That's okay. So I think
Even sir, even if there is no any axillary, even there is no axillary lymph node. If the primary base tumor is more than 2 centimeter, it's better to give neoadjuvant.
any evidence?
Evidence, even it is mentioned in the guidelines.
No, the guideline is another thing. The guidelines is both things. If you go to the NCCN guidelines, this varies. It depends upon the.
There is a possibility of around 40, more than 40% pathological complete remission. It has been.
So I will come to that later on, but that's true. I think you have both the abilities. You can go for the surgery first or preoperative treatment. There is no doubt. But thinking about the patient, because he didn't undergo the PET scan recommended diagnostic workup, I think this becomes quite reasonable that we start with the preoperative treatment. I agree with that. So whatever was done is good. The next thing, you selected the patient for paclitaxel and cyclophosphamide. So do you want to give another alternative of the chemotherapy, or was it good? Because just for surgeons, we don't know much about the chemotherapy. We have a simple funda, simple. Any CAF, CMF, or this 4AC40, etc. Or docetaxel, trastuzumab, paclitaxel, carbopaclitaxel, something simpler versions we know, but the very high versions we may not be knowing. So just want to clarification: is this regimen justified or is equivalent to whatever is recommended? It's good. Pardon? Cyclophosphamide.
I think in case of early disease, in case of early breast cancer, especially in case of blood pressure. So, in case of blood pressure, we are thinking that the patient will be cured and the survival will be longer. Then, doxorubicin has been withdrawn from the guidelines since last experiment from the literature. And another thing, sir, the patient is of as well as if you consider it as a T2N1, it is quite justified. Because this is a gray zone in the classification of the audio or globally advanced breast cancer. If you consider it as a T2N1. So if we see this, then I think use of taxane along with cyclophosphamide plus auto therapy is quite justifiable. Alternate only that if there is an extensive disease, like let's say the cross equals stage 3 or locally advanced, then addition of the drug solution would be more advantageous. Further, sir, the question is zero, and we haven't checked other criteria like other molecular testing like P50 mutation or the fragments level, where drug solution have related contaminants. It has shown that we haven't checked the extensive NGS panel there, sir. It would happen by
No. Have we checked? I think no. But we can advise the person.
Yes, sir. Because these accounts for only 10% of the breast cancer. If we see B4 P53 mutation, it is present in prevalent in more than 50% of the Asian population. And this has a relative contraindication for RT, relative contraindication for drug solution, relative contraindication for photosis. This can be used to say earlier appearance of this panel language. So, in this case, patients 25 years old, I think the
This panel is justified.
might think that this is the case of breast cancer with possible hereditary involvement. That's basic.
That's good. So, I think
One question. In the case of this minimum disease, is there any giving chemotherapy? Is there any ultraviolet function? Cytoplasm like that?
There was no orthogonal function
right
in this case.
control. Well controlled.
That's a good part. And second part regarding choosing white TCS was chosen. One of the reasons this patient is young and we expect we treated this case as a curable malignancy. And every one of us know that doxorubicin as was cardiac disorder. So in long-term patient might develop some cardiac complications. That was one reason. And second reason was either we give trastuzumab weekly or 3 weekly. And when we are using adamycin and cyclophosphamide, we need to use 2 weekly. And that becomes difficult for the patient to come every week for the trastuzumab. That is the second part. And third is like if you go through the guidelines in early, like if the disease burden is low, response of AC brought by T with trastuzumab or trastuzumab, cyclophosphamide and taxol. The response is almost equal.
That's good. So this has been clarified. The next question comes, if we go to, I think Dr. Mahesh has shown in one of the NCCN guidelines that it has to be doxycycline, docetaxel and cyclophosphamide. Docetaxel is equivalent to taxol, that's CO4. So it has to be given for 4 cycles. Why did you select for 6 cycles? There's a specific reason?
No,
Number of cycles.
Number of cycles in the chemotherapy cardiac, we have made the 6-8 cycle. That doesn't mean that we are planning to go for 6 cycle. We went 4 cycle and the patient was sent for surgical evaluation. And I have to check the file.
There was some delay, that's why 6 cycles.
Yeah.
That's okay. That could be the reason. The next question, very important.
3 cycles or we have to wait for 4 cycles?
Whenever you are giving TCS, it's good to go for 3 to 4 inches.
4 cycles, yeah. So okay, so that's very well clarified. So now,
Instead of this cyclophosphamide, why did you choose carboplatin? Paclitaxel, trastuzumab and carboplatin is the
Carboplatin was not taken considering the medical patient is under microcurrent mobility cardiovascular with the proven MRT. So carboplatin only.
that's good. So the very important question now comes that the affinity trial showed that you can add the second in HER2 targeted therapy, HER2 directed therapy. So adding to the trastuzumab, the another pertuzumab, etc. So do you think, can you explain something in few words? Is it recommended, it's needed or not?
Patient can afford trastuzumab with pertuzumab is better option. And she was explained for the pertuzumab, but that costs somewhere around 1 lakh plus per cycle. And if you can still constant, they will refuse that.
So do you think some drawbacks of this kind of treatment?
Pertuzumab,
Now with the dual
in our context, trastuzumab is
if the
more
patient can afford.
the patient can afford, might be pertuzumab would be a better option, but I have no experience of using pertuzumab.
So why I raise this question is sometimes maybe the drug is overused. So there is a very good publication in BMJ in 2018. I cannot find the whole article, but the abstract says this was presented by the surgical oncologist. He is a professor of surgical oncology in Silver Center. He was trained in Tata Memorial Hospital. He says, so we should rethink about the neoadjuvant chemotherapy. So you go to the affinity trial. He says his name is Sambaidya, Jaswant Vaidya or something. So it's very logical, very rational. He says, he raises the question, the affinity trial says that if you could do this kind of treatment, dual, HER2 directed, the local recurrence rises up to 25%. Then what would you say to the patient? If you are doing the dual treatment with the preoperative chemotherapy, your local recurrence is going to be high. At the same time, the overall survival remains the same. So how you are going to explain the patient? You are telling the patient that doing this kind of treatment, maybe you will be capable for doing the breast conservation surgery instead of mastectomy. And it proved that if you do the breast conservation surgery, then the resurgery rate, mastectomy rate, because of the positive resection margin or incomplete surgery was even higher the rate of 30 or 40% is the incomplete surgery was performed because of the breast conservation, and they needed to convert into mastectomy. Then is it useful? Really useful? So that's a very valid point from the surgical perspective. He has raised the question, and I think in one of the meetings, international meeting, I don't know whether it was asked for or not, they have raised this point also. So do you have any? Maybe this is the company-driven drug, or is it really needed? The advantage, I mean, the absolute difference, there is no absolute difference. Overall survival is same. They are mentioning the some invasive disease-free survival. He said, what is this invasive disease-free survival? We know the disease-free survival. We know about, we can talk about the progression-free survival. We can talk about the overall survival. So they have mentioned this one. So he is critically viewing this ability trial. Maybe this could be the company treatment. So I think what we have been doing, just using the single drug will be better than the dual HER2 directed therapy. So I think just my recommendation, you can also go to the YouTube or somewhere literature, you can find his discussion is very important and very logical.
Pertuzumab with trastuzumab is discussed in most of the conference. Even last time I was in Vietnam, we discussed the same thing. What survival we are getting, adding pertuzumab for 12 years, expanding around 12 lakhs living service. And survival benefit is around 3, more than 5 or 6%. So
this affinity trial showed that the complete pathological response he said is 40%. It's higher, right? In the range of 40%. If you
I think sometimes newspaper or something that trial shows the rate of local recurrences low if we get your
but this the randomized trial is just opposite. Local recurrence is higher. So this is the difference in them. So now the next thing comes. This patient we kept the future gold. So now what happens if there's the complete response? This patient didn't have the complete response. We were expecting 40% of the complete responders. So how the surgeon is going to find out what kind of surgery they will do? If you are not planning for the mastectomy, the patient is insisting for the breast conservation surgery, how will you find? What is the reason? So I think for the breast surgeon, my personal recommendation, if the patient is willing for the breast conservation surgery in future, then please mark it somewhere. And this code is available here, the judicial. So you can use it. So in one of the CT scan, you might have noted there is some foreign body artifacts, so that check is simple. So you can put it there. And for the planning for hours, we can detect. Though if it is not able, the patient cannot afford, but I think this costs about 4,000 rupees or 3,000, I don't remember. Pardon? 12,000. Then we can at least make the tattoo, skin tattooing with this Indian ink. That could be okay. So that can be done. Sir, just a moment. Just continue. Hello. Busy text.
It is better to put judicial marker in post of its surgical wear also.
Possible.
Because it helps in the tumor post. That's all. You will get it. Yes. Sometimes this can is difficult and difficult for and sometimes the brain side also. The brain side is part of it. This is what we should hear of brain side
So yeah, this is now I was just so now the patient has completed this one. She has got the residual disease. So now we have the option of breast cancer. The patient is willing for the breast
do you
cancer.
want to add further chemotherapy? Make it negative. Out of that.
no, patient has already received 6 cycles. Taxol based. So if the surgery surgically operable, I think you'll have to go for that. But patient is willing for breast conservation surgery.
It's
That's what the
possible.
medicine.
It's possible.
That possible.
That's
I
possible.
think at this point of time, I think it's good to wise to go for surgery because you have to go for second line chemotherapy along with trastuzumab. So when you are planning to change the chemotherapy, then it's good to go for one of the modality of treatment that is surgery, and then we consider for actual chemotherapy if we find that there is a residual disease.
Yes, we are planning. I mean, the breast surgeons are planning for the breast conservation. So this possible the patient desires that also. Now the next question, the surgical part we will made this. Next question, we did the surgical procedure. You might have been receiving a lot of patients after breast conservation surgery. You all of them you are irradiated after the surgery. How you are going to find where do you irradiate? Have they picked it? Some marker was placed. How you are planning for the breast, the radiation therapy? Or simply you are planning for the whole breast radiation. So is there any option of doing the partial breast radiation? Not the whole breast, that's okay. But you have to do the boost. How you are planning exactly where to put the boost? Where to
Yeah,
put the boost?
I am just talking about that. We put the position marker on the operating gate, and it is better for localization. Otherwise we have to rely on the scar and pre-operative imaging and
So that's again comes to the surgeons. So let's start doing something. At least we put some clips that's available now. Download the gold edition. You can just metal clips, titanium clips that can be marked there so that they can find out where to give the boost irradiation. Now my next question comes to you. Can we do the partial breast irradiation? Why in every patient should be given the complete breast, whole breast irradiation? In a context of BCS.
with a small size tumor with large breast, about 2 to 3 centimeters, can give partial breast irradiation, but we are not practicing it.
Can it be done here?
Yeah, we can.
Yes. So I can start that also. That is one of the benefits for the patient. And also just to remind you one more thing, the surgeon said in his article why they received the 40% complete response pathologically, but yet they have got the similar overall survival. He mentioned the pathology, how the pathology is saying that this is the complete pathology. How many sections they evaluate? If you do 1 mm, that is the one slice. So for evaluate the 2 centimeter lump, you have to make 6,000 of the slices. Is it possible? So how can you comment that this is totally pathological complete response? You're taking the standard, maybe because in the breast, this is the honeycomb pattern of the response could be there. So how are you totally sure that after the affinity trial, whatever we have given, there is the complete pathology? That could be reason the overall survival is the same. So this one thing. So okay, so this patient, if we are considering for the breast conservation, we can give without any problem irradiation therapy. It's the relative contraindication, not the absolute. So you can still give the patient. So now let's suppose the single lymph node is positive. Just for the surgeons, we have done the axillary dissections. So you will do the whole breast irradiation so far now, just now. Which nodal extraction would you irradiate? Just for our information. Do you irradiate the axilla also, or do you irradiate some particular lymph node extractions?
We are not eating regular axillary boost. Otherwise, it is the severe tumor or positive margin or sternodal extension. Otherwise, we give the avoid the axilla because already dissection of level 1 and level we have to draw. We cover the unattended axilla plus supplicated because of not positive. Young patient, in this case, we cover that along with the test.
Yeah. So that's good. So anything else? तब डिस्कस मत 2 minutes 1 minute तब डिस्कस करो. Any questions from the residents? Any comments?
We're not doing P53 and other things. If the P53 is white, then they're supposed to be more radiation sensitive. If it is mutant, then less radiation sensitive. It's not contraindication for radiotherapy. It's just like it is supposed to be less radiation sensitive. I think so. It is not like it will be radio resistant and statistically progressive. So it's not contraindication. We have to give radiotherapy. If we have P53, then we can predict whether that is going to be radio resistant or less radio sensitive or more radio sensitive. And if it is more radio resistant, then I think we can think about some of the targeted that is. Another case, another like ATM mutation also. If ATM mutation is there, then they are supposed to be the more sensitive. So tumor cells will be more radiation sensitive, and because in radiation there will be single strand break and double strand break. So this ATM mutation is more responsive towards the double strand break, and the tumor cell there will be more local control. But the normal tissues will also be irritated. So there will be more toxicities in the normal tissues. In such case, like nowadays we are having very microfractionated series, but if it is ATM mutation, then we can actually follow the conventional 25 fractions like that in that case. So I think from radiation oncologist point of view, PBT3 and the ATM, if that is done, it will be better. If the patient is affording and we have facilities.
Patient is affording, like if you are talking about 5,000, 10,000, 20,000, and to be very frank, patient can afford to buy some vitamins of 20,000, 50,000 and 8,000 of clipping. We say that patient can't afford our medicines, first part. And second part, to all my younger breast onco surgeon, going each and every case for MRI, I think we'll have to rethink about that. Like not only someone mentioned, go for clipping and again, district patient, they need to have, they prefer to have some cosmetic look. So I think going for PCS is a good option, rather than going for conventional what we have been doing. Because you are the younger one, and you need to think about that. And my thought is like patient, they are operating somewhere else. They come here, and I think we need to do something extra. We go for MRI. I think we would have to really think about that. And again, breast is one of the, not one of the, but the only one cancer with good and better prognosis. So I think we'll have to change our mindset about treating the breast cancer. Like each and every case, I think it's good to start initiated MDT. So, but at least for breast cancer, we can be in that.
During the first one, doesn't work out well. BRCA1, BRCA2 is necessary in this case.
Because I think if it is BRCA carrier, then we do not go for PCS.
Why? Why?
Patient also had evidence of
If
adnexal cyst and with increased CA1.5, maybe it was not very indicated.
PCS गर्न मिल्छ
विशेष गर्न मिल्दैन
We might have to go for
We should have to go for MRI.
prophylactic mastectomy as well.
यसमा चाहिँ नि BRCA1 BRCA2 को आउँछ जस्तो लागेको थियो
Adnexal cyst, raise CA125 and aggressive
It's
tumor.
necessary findings are here. We didn't know. In a young patient,
युजुअली मा चाहिँ इनिसियली नै पठाउन चाहिँ पर्दैन
initially पठाएको थिएन जस्तो लाग्छ
Because of for young patient that is familial, then we have to do the surgery of later on endometrium. We have to carefully assess the fertility test and also risk factor. We have to monitor the family also. This is good. Doing that fact.
So I think any more comments?
Looking at the age and the fertility status and minimal changes. So after the surgery, how do we plan for the post-HCT or radiation therapy to minimize the complication for the loss of fertility or further nephrotox? What is the plan?
She had concern with the fertility. So we tried to preserve our ovum, but unfortunately, like they to preserve ovum in post. And they have the indigenous adoption they do preserve, but it's worthless. That part was no. Second part, like regarding adjuvant chemotherapy, I think we'll have to request our pathologist dispatch the report at earliest to see is with the complete response or not. If it's the complete response, then I think we'll have to go for adjuvant radiotherapy followed by trastuzumab. But if it comes to be in a residual lesion, then I think we'll have to consider again for adjuvant chemotherapy plus minus.
No radiotherapy, there is no direct interaction. We are not giving to the vision of the kidney. Yes, we are.
मेरो एउटा question छ
त्यसमा तिम्रो fertility event जस्तो लागेको छ
Maybe. यो त पछि अब because chemotherapy.
Regarding the cases of the case of patient is less than 50 years of old, less than 50 years of age, and we should go for the hereditary breast cancer screening, sir. But in this case, particularly the horticulture patient with excess of beta-2 being used. But the age is the factor. Beta-2 are usually point. This one cancer are found beyond 40 years of age. Regarding the fertility presentation, we cannot go for ovarian tract presentation. We can go for CNRH and we can give 1 month prior to the non and keep the ovary in the development force. Because chemotherapy will affect the rapid dividing cell and the oocytes are being rapid dividing cell. That's why you keep them in development form. This is a, I don't know how much effective is this, but this has been done.
And then the last question from Sandeep, then we'll delve.
Mere question, sir. If we have done NGS in this case and the tumor comes P53 positive, which says the radio resistant type of case, so I see radiation the plan ki different on there. Like हमने NGS पठाएको भए के बेनिफिट हुन्थ्यो बिरामीलाई P53 आयो ATM पनि आयो मानिलियो P53 पोजिटिभ छ रेडिएसनको प्लान त केही छैन
प्लान के चेन्ज हुँदैन तर एन्टिसिपेसन चाहिँ रेडिएसन बेनिफिट कम हुन्छ भने
I think one of the relative contraindication for the ATM positivity is the breast conservation surgery. I think absolutely. So we should go for the mastectomy rather than the PCS. That could be one of the options.
In this case, after mastectomy, if there is a residual disease, we will go for adjuvant trastuzumab. And if there is a complete remission, pathological remission, then we can continue with trastuzumab. If there is a residual disease in lymph node, then we will continue trastuzumab, that is TDM1, which is a intensive in the which is a antibody drop of weight. That will be 14, I think 14 sign.
If there is a residual disease and because the blood weight setting the chemotherapy was not effective, what sort of chemotherapy will it be in the actions? There is residual disease. I think this is
Residual disease also because it is already
we can go for a child because the residual disease should have the aggressive immune system and the chemotherapy should have worked. But the disease seems to be relatively resistant to chemotherapy.
No. It has the main tumor has regressed. I think there is a partial response in the tumor.
From where the vaccine was taken?
From the tumor and the FNA from the axilla. So lymph node is still there, but the main tumor has regressed by 50%. It has regressed. I think there is the response. We cannot say there is no response.
There might be
So I think let's conclude with this case. Thank you very much for coming. So I think this was a very healthy discussion. So we'll plan that patient will undergo the breast conservation surgery as per her desire. Then we shall refer the patient to the radiation oncologist for the adjuvant radiation therapy. And according to the protocol, definitely she will receive the trastuzumab for 14 cycles as recommended by the guidelines. And so far as the adjuvant chemotherapy is concerned, so we'll decide according to the final pathology. Right? We'll convince the patient for the NGS also to find out any mutations are present in her body. So thank you very much for coming.
We are providing ribociclib and letrozole to all our patients free of cost. There are some
Ribociclib.